Okay, let's unpack this. You know that feeling, just utterly drained, maybe a bit dizzy, like you're moving through mud all day.
Mm.
We often chalk it up to stress or, not enough sleep. But sometimes that feeling could be your body telling you something else is going on, something like blutter mode or anemia.
Yeah, that sense of persistent fatigue, of just not being quite right, it's incredibly common.
Yeah.
And yes, it's often the first thing people notice if they have anemia.
Right.
At its heart, anemia means you have too little hemoglobin. Think of hemoglobin as the crucial protein inside your red blood cells.
The oxygen carrier.
Exactly. Its entire job is to grab onto oxygen in your lungs and carry it to every single part of your body. So when your hemoglobin is low, your tissues and organs just aren't getting the oxygen they need to, function properly.
And today we're doing a deep dive into the actual blueprint the doctors here in the Netherlands use when they're diagnosing and managing anemia. We're cracking open the latest clinical guidelines.
The standard, yeah.
The kind of detailed standard that shapes medical practice. Our goal is to give you a shortcut, pulling out the absolute most important insights and maybe some surprising facts from this expert document. So you can be truly well-informed about what anemia is, the many reasons it happens, how doctors investigate it, and what the modern approach to treatment looks like. Forget everything you thought you knew about just taking iron.
Our mission is precisely that, to go beyond the surface and show you the layered complexity behind what seems like a common condition, straight from the source medical professionals rely on.
All right, let's start at the absolute foundation as defined in these guidelines. What are the numbers that medical professionals are actually looking at?
Well, anemia is officially defined by a hemoglobin level, or HB, that's below a certain threshold for your age and sex.
Okay.
According to the reference values in the standard for adults, that cutoff is typically below 8.1 millimoles per liter for men.
Okay, 8.1 for men.
And below 7.5 millimoles per liter for women.
7.5 for women. Got it.
Millimoles per liter, small, it's just a standard medical unit to measure the concentration of something in your blood. And there are different thresholds for children based on age, of course.
Right.
And labs can have slight variations, but those are the adult benchmarks we generally use.
So it's a specific measurement of that oxygen carrier, HB. And you mentioned age and sex matter for the definition itself. To understand why that number might be low, the guidelines introduce a couple of key terms right away, don't they?
Yes, absolutely. Keep two terms in mind because doctors use them heavily in the investigation. MCV and ferritin.
MCV and ferritin, okay.
MCV stands for mean corpuscular volume. It tells us the average size of your red blood cells. Are they typically small, normal sized, or large? And ferritin is a protein that serves as your body's main iron storage unit. Measuring the amount of ferritin in your blood gives a pretty good estimate of how much iron you have in the bank, so to speak.
Okay.
Though we'll see later it can be affected by other things too, like inflammation.
Okay. Low HB is the definition. MCV and ferritin are key tools. But why dedicate a whole deep dive to this? How prevalent is anemia? Is it really that common?
Oh, it's far more common than many people realize in general practice. The guidelines cite data showing an incidence of 8.6 cases per 1,000 patients per year in primary care.
Wow, okay, 8.6 per 1,000.
Yeah. And when we look at the causes, iron deficiency anemia is the clear front runner. It accounts for roughly half of all anemia diagnoses.
Half? Really?
Yeah, seen in 4.3 out of every 1,000 patients each year.
That number is significant. And you mentioned sex as part of the definition, but the statistics for iron deficiency are even more striking between men and women, aren't they?
They really are. Women are diagnosed with iron deficiency anemia about 4 times more often than men.
4 times.
Particularly in their reproductive years, say between ages 15 and 50. The reason is pretty straightforward, actually, and directly linked to common physiological processes.
Right.
Heavy menstrual bleeding or the increased iron demands during pregnancy.
Right, losing blood regularly or needing more for pregnancy.
Exactly. These are major routes of iron loss or increased need.
That explains the difference in younger adults. But it's definitely not the only reason someone might become anemic.
Oh, not at all. While iron deficiency is the most frequent, other causes are also quite common. Vitamin B12 or folate deficiency, for instance, they account for about 1.8 per 1,000 cases annually. These are seen more often in older adults, sometimes those with specific dietary restrictions like strict veganism,
Right.
individuals with conditions affecting nutrient absorption in the gut, or, issues like alcoholism can play a role too.
And then there's the genetic side, right? Conditions people inherit.
Yes, the guidelines discuss hemoglobinopathies. These are genetic conditions affecting either the structure or the quantity of hemoglobin produced. Think conditions like sickle cell trait or the thalassemias.
Okay.
It's estimated that about 1% of the population in the Netherlands are carriers for one of these conditions.
1%, so not insignificant. So bringing this back to you, the listener, that feeling of being tired could be anemia. But as we're seeing, these guidelines show doctors have a very specific kind of layered process to figure out which of these different causes is behind it. It's not just a simple checklist.
Exactly. The correct diagnosis is absolutely critical for effective treatment. And actually, on the subject of diagnosis, one of the major points highlighted in these updated guidelines is a significant shift, a real change in how doctors are encouraged to think about pinpointing the cause of anemia.
Oh, interesting. Tell me about this shift. I understand the old way heavily relied on the size of the red blood cells.
That's right. The previous approach often categorized anemia based on the MCV, the cell size. Was it microcytic, meaning small cells, normocytic, normal size, or macrocytic, large cells? That morphology, that appearance, guided the initial thinking.
Okay, so if the cells were small, you'd think maybe iron deficiency first. If they were large, maybe B12 or folate deficiency.
Precisely. But the new approach emphasized in the guidelines is centered around the underlying pathophysiology.
Pathophysiology,
Yeah,
meaning the process.
exactly. Instead of just looking at the cell size, it asks, what process is causing the hemoglobin to be low? Is the bone marrow having trouble producing enough red blood cells? Are the red blood cells being destroyed too quickly, maybe? Or is there acute blood loss happening?
Why is focusing on the process better than focusing on the appearance? What's the advantage there?
Well, because this pathophysiological view aligns much more directly with the subsequent steps in investigation and, crucially, the specific treatments available. Plus, as the guidelines point out, many types of anemia actually start with normal-sized red cells
Oh, right.
before the size changes become apparent later in the disease process. So relying just on size early on can sometimes delay or even misdirect the investigation.
Ah, so this new perspective means doctors might catch things earlier or get to the root cause more efficiently. How does this change the initial tests ordered then?
This is one of the practical impacts, yeah. The first step in additional lab diagnostics, when they're needed, is no longer just looking at MCV in isolation. It's now explicitly recommended to look at MCV in combination with ferritin right from the start.
The size of the cells and the iron storage together.
Yeah.
Okay. That makes a lot of sense given how common iron deficiency is. Right, let's dive deeper into some of the main causes you mentioned, particularly those under the decreased or disordered production category, which seems to be a big focus in the guidelines.
Certainly. Iron deficiency anemia, or IDA, remains the most common cause, as we said. Its mechanism is pretty simple. You lose blood over time, you lose iron, and without enough iron, your body can't build enough hemoglobin to carry oxygen effectively.
Makes sense. And for men and older women, where is that chronic blood loss often coming from, according to the guidelines?
This is a really important point highlighted in the guidelines. For men and for women over the age of 50 who aren't having heavy periods, chronic bleeding in the gastrointestinal tract, the stomach, or the bowel is flagged as a frequent and significant cause that needs investigating.
Okay.
Remember ferritin. A low ferritin level is the most reliable indicator here. It only means your iron stores are depleted. Low ferritin equals low iron.
Got it. Low ferritin equals low iron in the bank.
Mhm.
Okay. What about the B12 and folate deficiencies? You mentioned these often result in larger cells, hence the term megaloblastic.
Yes, that's the typical appearance, though, like we said, not always right at the very beginning.
Yeah.
B12 and folate are absolutely essential for the production of DNA.
DNA, the instructions for making cells.
Exactly. Think of DNA as the instruction manual for making new cells rapidly and correctly.
Wow.
Without enough B12 or folate, the bone marrow, which churns out red blood cells constantly, struggles to make them properly. They tend to end up larger and fewer in number.
How do people actually develop deficiencies in these vital vitamins? What goes wrong?
Well, for B12, the most common cause mentioned in the guidelines is an autoimmune condition called autoimmune atrophic gastritis, often referred to as pernicious anemia.
Pernicious anemia.
In this case, the body mistakenly attacks the cells in the stomach that produce something called intrinsic factor, or it attacks the intrinsic factor itself.
Intrinsic factor. Sounds important.
It is. It's like a required ferryman that helps B12 get absorbed properly in the gut. Other causes include stomach or bowel surgery, conditions like Crohn's disease causing malabsorption, or very strict vegan diets, since B12 is primarily found in animal products.
Right.
Your body does store B12 for years, though, so deficiency purely from diet usually takes quite a long time to develop.
And a surprising fact I picked up from the source is that B12 deficiency can show up in ways other than just anemia, right?
Absolutely. This is a critical detail. B12 is also vital for the nervous system. So sometimes neurological symptoms like tingling, numbness, balance problems, or even memory issues can appear before the anemia itself is severe enough to be noticed or diagnosed.
Wow. That's a crucial point for diagnosis, definitely. What about folate? How does that deficiency happen?
Folate is found in foods like leafy greens, beans, and liver. Unlike B12, the body's folate stores are much smaller and can be depleted relatively quickly, often within just 2 to 4 months.
Much faster than B12 then.
Much faster, yeah. The guidelines note that a common cause of folate deficiency is simply a poor diet, which is sometimes seen in situations like alcoholism, for example.
Okay, so we have iron deficiency, usually from blood loss, B12 folate deficiency impacting cell production due to absorption issues or diet. What about this anemia of chronic disease or infection? This one sounds different because it's not necessarily about lacking the ingredients.
Exactly right. This type of anemia isn't typically caused by a straightforward deficiency of iron or vitamins. It's more like a response to ongoing inflammation, infection, or chronic illness.
A response, how does that work?
Well, the body actually often has iron available, but it's sort of locked away, unavailable for making hemoglobin. Inflammation interferes with iron release and use. Plus, inflammation also tends to suppress the production of EPO. That's the hormone that tells the bone marrow to make more red cells.
So the body holds on to the iron and tells the factory to slow down production, basically.
That's a good way to put it, yes.
What kind of conditions trigger this response?
Common culprits listed include chronic inflammatory conditions like rheumatoid arthritis, persistent infections, certain types of cancer, and significant organ diseases, particularly kidney or liver disease. It can also be a temporary issue, for instance, in young children after an acute infection.
And this is where ferritin gets complicated, right? Because you said earlier, low ferritin means low iron.
Yes, this is a key nuance the guidelines clarify. Ferritin is what we call an acute phase protein. Meaning its level in your blood goes up when there's inflammation or infection anywhere in your body, kind of like a general alarm signal, regardless of your actual iron stores.
Ah, okay.
So in anemia of chronic disease, your ferritin level can actually be normal or even high because of the underlying inflammation, even if there's also some degree of iron deficiency happening at the same time.
So you could have both low iron and inflammation.
Precisely. Which is why doctors need to look at other iron markers too, like serum iron levels and transferrin levels, to get the full picture in these cases.
How do those help distinguish?
Generally, low iron and high transferrin usually point towards simple iron deficiency, but low iron with normal or low transferrin is more suggestive of anemia of chronic disease, where the body isn't making much transferrin because it's trying to lock iron away.
That's a really important distinction. If you just saw a normal or high ferritin, you might miss the iron issue if there's underlying inflammation. Okay. What about the genetic conditions, the hemoglobinopathies?
These are inherited, plain and simple. Someone is born with them because they inherited specific genes from their parents that affect how their hemoglobin is made. Sickle cell disease affects the shape, making red cells rigid and sickle-shaped under certain conditions. Thalassemia affects the amount of hemoglobin produced. There's just less of it made.
And the guidelines make a distinction between being a carrier and having the disease.
Yes, they differentiate between being a carrier or having the trait like sickle cell trait or thalassemia minor, which usually causes only mild or sometimes no anemia at all, and having the more severe major forms of the disease, which are much more serious.
And there's a crucial warning in the guidelines about giving iron to people with these conditions.
Yes, this is absolutely vital. For individuals with hemoglobinopathies, giving iron supplements is generally not helpful and can actually be harmful.
Harmful, why?
Because they're often prone to iron overload, accumulating too much iron in the body. So iron should only be given if laboratory tests confirm they have a separate coexisting true iron deficiency.
Good to know. And screening helps identify this.
Yes, the universal heel prick screening for newborns in the Netherlands helps identify both carriers and those with severe forms very early on.
And you briefly mentioned other potential causes beyond these main ones.
Yeah. The guidelines also briefly touch on things like primary bone marrow disorders, where the factory making blood cells is the problem itself, like some leukemias, and also hemolytic anemia, where red blood cells are being destroyed too quickly in the bloodstream for various reasons.
Okay, so we've covered the definition, the impact, that is important shift in diagnostic thinking, and the main categories of causes. Now, how does a doctor actually navigate all this complexity? What does the investigation process look like? according to these guidelines?
Well, interestingly, the guidelines actually start by outlining situations where additional testing is not necessarily the immediate first step.
Really? When would a doctor say, let's hold off on the blood tests for now?
According to the source, for premenopausal women who have anemia and also report heavy menstrual bleeding, the likelihood of iron deficiency just from that blood loss is so high that immediate extensive lab testing isn't always deemed necessary.
So they might start treatment first.
Often, yes, based on the strong clinical picture. Similarly, for infants and young children with mild anemia who have recently had an infection, that temporary anemia of infection is often assumed, and testing might be delayed just to see if it resolves on its own first.
So it's about recognizing those high probability scenarios first. Smart?
Yeah.
But if you don't fit into those specific groups, or maybe if the anemia is more severe?
Then yes, additional laboratory testing is definitely indicated. And as we discussed, the standard initial tests recommended now are MCV and ferritin together.
Right. Size and storage.
Exactly. And it's also noted that if your hemoglobin is measured by a finger prick device in the doctor's office, like a HemoQ, especially if the value is low, the guidelines recommend confirming that result with a formal laboratory blood test, just because those finger prick measurements can sometimes be a bit less precise.
Good point. Accuracy is key, especially with low numbers. What other tests might be ordered alongside MCV and ferritin right from the get-go?
Well, that depends entirely on the doctor's suspicion, based on your medical history, your symptoms, and the physical examination.
Okay.
If anemia of chronic disease is suspected, for example, they'd likely add tests like ESR or CRP, inflammation markers, serum iron, transferrin, and check kidney function with an EGFR test.
Right.
If B12 or folate deficiency seems likely, they'll check those specific vitamin levels. If a hemoglobinopathy is a possibility based on your ethnic background or family history, specialized tests like HB electrophoresis might be ordered early on.
I've heard that labs sometimes do extra tests automatically if something looks off. Do the guidelines mention that?
Yes, they do. They refer to this as reflex diagnostics or sometimes anemia diagnostics packages offered by some laboratories.
Reflex diagnostics.
Yeah, it means if a doctor orders a basic set of anemia tests, the lab system might automatically trigger additional relevant tests based on those initial results. For instance, checking B12 and folate if the MCV comes back high without the doctor needing to place a separate second order.
That sounds...
It can be. The guidelines advise doctors to be aware of what their local lab's standard anemia panel actually includes or triggers.
So the doctor combines your story, the initial physical check, and these tailored lab results, maybe with some reflex testing to diagnose a specific type of anemia.
Precisely. The section in the guidelines dedicated to evaluating the results, the evaluatee, lays out how the combination of HB, MCV, ferritin, and any additional tests helps differentiate between the causes we've discussed.
Can you give an example?
Sure. So a low HB, a low MCV, small cells, and a low ferritin together are the classic picture of iron deficiency anemia. Pretty straightforward.
Okay.
But say a low HB, often with a normal or high MCV, normal large cells, and low B12 or folate levels point strongly towards a vitamin deficiency.
Right.
And then a low HB, maybe normal or low MCV, but a normal or high ferritin combined with low serum iron and normal low transferrin. That pattern leans heavily towards anemia of chronic disease, as we discussed.
Okay, so the pattern of results is key. Now, the cause is identified, but the guidelines make a very specific, quite serious point about certain patients with iron deficiency needing further investigation to rule out something else. This sounds like a critical takeaway.
It absolutely is a critical directive from these guidelines, yes. And it's something people really need to be aware of. If you are a man over the age of 50, or a woman over 50 who does not have a history of heavy menstrual bleeding.
Okay, men over 50, women over 50 without heavy periods.
And you are found to have iron deficiency anemia, the guidelines essentially mandate further investigation. It's not optional.
And the specific concern in that demographic is what, exactly?
It's to rule out a gastrointestinal malignancy.
Cancer.
Yes, cancer in the stomach, or, more commonly in this age group according to the data, in the bowel or colon. Iron deficiency in these patients is often the only, or perhaps the earliest, sign of chronic, otherwise unnoticed bleeding from a tumor.
That sounds incredibly important to catch early. How is that investigation typically done?
It involves looking directly inside the GI tract using endoscopes. So that means a gastroscopy to examine the stomach and esophagus, and/or a colonoscopy to examine the colon, the large bowel.
Okay, scopes. Is there an order they usually do them in?
Yes. The guidelines specify a preference based on probability. Unless you have symptoms clearly pointing to the stomach, like specific pain or indigestion, the recommended first step is usually a coloscopy.
Look in the bowel first.
Right. Then, if the coloscopy doesn't find the source of bleeding, a gastroscopy would follow. This order is based on data suggesting that bowel cancers are statistically more frequently the source of blood loss, leading to iron deficiency in this particular patient group.
So they target the most likely source first based on the stats. Makes sense. And what about other tests people might think of for bowel issues, like stool tests for blood or certain x-rays? Are those useful here?
This is another crucial point the guidelines are very clear on. They explicitly state that an x-ray of the colon, like a barium enema, used to be common, and the fecal occult blood test, FOBT.
The stool blood test, yeah.
They state these have no established value in investigating the cause of proven iron deficiency anemia in a patient who is already showing symptoms like the anemia itself.
No value. Why exclude those if they can sometimes detect issues?
The guidelines explain that these tests, particularly FOBT, just aren't sensitive or specific enough for this particular diagnostic purpose. FOBT, for example, is designed primarily as a broad screening tool for asymptomatic people in population screening programs.
For people without symptoms.
Exactly. It's not considered adequate for reliably finding the source of bleeding in someone who has already lost enough blood chronically to actually become anemic. Endoscopy is really required for a definitive investigation in that scenario.
Okay, that's very clear. Endoscopy is the standard for that group. Are there any other follow-up investigations mentioned for other situations?
Yes, briefly. They mention potentially testing MMA or homocysteine levels if B12 results are borderline, but the doctor still strongly suspects a deficiency. Considering genetic testing if a hemoglobinopathy is suspected, but the initial tests like electrophoresis are maybe unclear, and importantly, advising family members about testing if a carrier state for a hemoglobinopathy is identified in someone.
Okay, we've journeyed from understanding the problem and its causes to the detailed investigation process, including those absolutely critical follow-up steps for certain patients. Now, let's talk about what happens once the diagnosis is actually made. What does management and treatment look like according to these new guidelines?
Well, the fundamental principle, which really can't be stressed enough, is that treatment must target the underlying cause of the anemia, not just the low hemoglobin number itself.
Treat the cause, not just the number.
Right. And while good nutrition is always beneficial, of course, relying on diet alone to fix established anemia is usually insufficient. Unless perhaps it's a direct result of a very severe dietary deficiency, like maybe strict veganism without any B12 supplementation, or perhaps in the context of alcoholism leading to folate deficiency.
Gotcha. And for people identified just as carriers of hemoglobinopathies, like thalassemia minor.
Right. If you're identified as a carrier for a condition like thalassemia minor or sickle cell trait, and the anemia, if any, is mild or asymptomatic, typically no specific treatment is needed for the anemia itself. And again, crucially, iron supplementation should only be given if you have proven coexisting iron deficiency from a separate cause because of that risk of iron overload we mentioned.
Okay. Now the big one. Iron deficiency is super common, and you mentioned a significant change in how iron supplements are prescribed. This sounds like a major insight from the guidelines.
It really is. This truly challenges the old standard way of doing things. For adolescents and adults diagnosed with iron deficiency anemia, the new recommended starting dose of ferrous fumarate is 200 milligrams, taken just twice a week.
Twice a week, not daily. That seems counterintuitive if you're deficient. Why would they recommend less frequent dosing?
It does seem counterintuitive at first glance, yeah. But the guidelines cite growing evidence indicating that this intermittent dosing schedule twice a week is actually just as effective at raising hemoglobin levels and replenishing iron stores as the traditional daily dosing.
As effective, but fewer pills.
Exactly. And here's the critical part. It leads to significantly fewer side effects, particularly those common gastrointestinal issues like constipation, nausea, stomach upset that often make people stop taking daily iron.
That makes a huge difference for actually sticking with the treatment.
It really does. There's also a theory it might improve absorption overall. Taking iron triggers a hormone called hepcidin, which temporarily blocks iron absorption for about 24 hours. Taking it less often might allow hepcidin levels to drop between doses, potentially letting more iron get absorbed when you do take it.
Fascinating. That's fantastic news for patient comfort and adherence. Fewer side effects sounds like a huge win. What about for children? Is it twice a week for them too?
No. For children under 12, daily dosing is still the recommendation, typically based on body weight around 3 milligrams per kilogram per day.
Okay, daily for kids, intermittent for teens and adults.
That's the new standard, yes. And the guidelines also express a preference for ferrous fumarate generally over other forms like some slow-release ferrous sulfate preparations.
Why ferrous fumarate specifically?
It seems to hit a good balance of effectiveness, generally having fewer side effects compared to some other simple iron salts, lower cost, and they even mention consideration of environmental impact from the plastic matrix used in some slow-release formulations.
Interesting. Any practical tips the guidelines offer for taking oral iron effectively?
Yes, they suggest taking ferrous fumarate in the morning if possible. And importantly, avoiding things like coffee, tea, or milk within about 2 hours before or maybe 4 hours after taking the pill, as these can interfere with absorption.
Okay, watch out for coffee and tea.
Right. Taking it on an empty stomach, maybe with some vitamin C, like orange juice, can boost absorption. But if
Mm-hmm.
that causes stomach upset, taking it with a small meal is an acceptable alternative just to improve tolerance. Compliance is key.
Good practical advice. Now let's talk about the equally significant change you mentioned regarding vitamin B12 treatment. This sounded like another big update.
Yes.
Injections aren't always needed anymore, even for absorption problems.
Exactly. This is another really surprising but evidence-based takeaway. For most adults with diagnosed B12 deficiency, even if they have conditions that impair absorption like pernicious anemia, inflammatory bowel disease like Crohn's, or have had stomach or bowel surgery, or are on medications like metformin or PPIs that can affect absorption,
Okay.
even then.
The new standard treatment recommended is oral vitamin B12 at a high dose of 1,000 micrograms daily.
Oral, 1,000 micrograms daily. Even with those absorption problems, how does the body actually get enough B12 that way if the normal route is blocked?
It relies on a different mechanism.
Yeah.
While the main way we absorb B12 from food requires that intrinsic factor ferrium we talked about earlier,
Right?
a small amount, maybe only about 1% of a dose, can actually just diffuse passively across the gut wall directly into the bloodstream.
Passive diffusion, like it just seeps through.
Sort of, yes. Even without intrinsic factor or a fully functional end part of the small intestine. By giving a very high oral dose, like 1,000 micrograms, that small 1% passive diffusion is actually sufficient to absorb enough B12 over time to correct the deficiency in the vast majority of patients.
That's incredible. So much easier than regular injections for most people.
Absolutely. It simplifies treatment significantly.
So injections are now the exception, not the rule. When are they still used? Correct. Injections or parenteral administration are now largely reserved for specific situations. Mainly if someone has significant swallowing difficulties making pills impossible, if they present initially with severe neurological symptoms from the B12 deficiency where rapid correction is critical, or perhaps if there are clear issues with adhering to the daily oral treatment plan.
Okay, that makes sense. And for folate deficiency, is that also oral?
Yes, folate deficiency is treated with standard oral folic acid, typically zero point 0.5 milligrams daily.
And it's absolutely critical to check for both B12 and folate deficiencies if one is suspected, isn't it? Why is that?
Crucial, yes, and the guidelines strongly emphasize this point. Treating a B12 deficiency only with folate can be dangerous.
Dangerous. How?
Because folate treatment can improve or even normalize the blood, counts the anemia part, making it seem like the problem is solved. But it does nothing for the neurological damage that B12 deficiency can cause. So giving only folate could mask the ongoing B12 deficiency, potentially allowing the neurological problems to progress or even worsen while the blood looks better.
Wow, okay. So always test both and treat both if both are deficient.
Absolutely. You need to know the status of both vitamins before starting treatment.
Got it. So once treatment begins, whether it's intermittent iron, daily oral B12, or folate, how do doctors monitor if it's actually working?
The primary monitoring tool is rechecking your hemoglobin level via laboratory blood tests, not usually finger prick for monitoring.
Okay, lab tests. How soon?
For iron deficiency, this is usually done about 4 weeks after starting treatment. You'd expect and want to see your hemoglobin level starting to rise noticeably, ideally by at least 0.5 millimol per week, or roughly 1 GDL per month if using older units.
And what if it's not rising as expected?
That's a flag to troubleshoot. The doctor needs to ask, is the patient actually taking the medication as prescribed? Are there interactions with food or other medications hindering absorption? Or is the initial diagnosis maybe incomplete? Perhaps there's another cause contributing to the anemia that hasn't been addressed, like ongoing hidden blood loss or maybe coexisting inflammation.
Okay, troubleshooting is key if the response isn't there. What about monitoring for B12 or folate?
Similar principle. HB is typically rechecked after about 4 weeks, and maybe again after 8-10 weeks, looking for that steady rise back towards the normal range.
And for iron deficiency, Once the hemoglobin number is back to normal, do you just stop the iron supplements then?
Not right away, no.
Yeah.
This is important too. The guidelines recommend continuing the oral iron supplementation for an additional 8 to 12 weeks after the hemoglobin level has fully normalized.
Another couple of months. Why?
That extra time is essential to fully replenish the body's iron stores to fill up that iron bank we talked about, which is what the ferritin test reflects initially. The dose might sometimes be reduced during this maintenance phase, say to once a week.
Okay, so get the HbO normal, then top up the stores.
Exactly. Interestingly, the guidelines also note that routine monitoring of ferritin levels during the treatment phase isn't usually necessary or recommended. The main focus is on the hemoglobin response.
Good to know. And for B12 or folate deficiency, is treatment always lifelong? You mentioned pernicious anemia.
It depends entirely on the underlying cause. If the reason for the deficiency is permanent and can't be fixed, like with pernicious anemia, where the body simply doesn't make intrinsic factor anymore, then yes, B12 supplementation will almost certainly be needed lifelong.
Makes sense.
But if the cause was temporary or correctable, like a short-term dietary issue that's been resolved, or maybe stopping a medication that interfered with absorption, then supplementation can usually stop once the deficiency is corrected, and stores are judged to be fully replenished, perhaps after 6-12 months of treatment in total.
Okay, depends on the cause being fixable or not. Finally, when would a GP look at these guidelines and decide, okay, this patient needs to see a specialist, like a hematologist or maybe a gastroenterologist for those endoscopies?
The guidelines outline several specific situations warranting consultation or referral. These include cases where the anemia isn't responding to the standard treatment as expected, despite troubleshooting, or if specialized procedures are clearly necessary, like the endoscopies we discussed for GI investigation, or perhaps if intravenous iron administration is needed because oral iron isn't tolerated or isn't working.
Okay.
Also, if the cause seems complex, for instance, significant iron deficiency combined with marked anemia of chronic disease making management tricky. Or if there's a strong suspicion of a more serious underlying condition, like a primary bone marrow disorder, significant kidney disease causing the anemia, or maybe hemolytic anemia.
Right, more complex or serious causes.
Exactly. Or simply, if the diagnosis just remains unclear after the initial round of investigations according to the guideline pathway. And of course, they briefly mentioned that blood transfusions might be considered for very low HB levels, especially in patients who also have significant heart or lung issues and might not tolerate the low oxygen levels well.
Wow. That was a truly comprehensive look into how medical professionals think about and manage anemia, all guided by these expert standards. We started with that simple, common feeling of fatigue and followed the path through defining anemia by the numbers, understanding that modern process-based way of diagnosing the cause, diving into the specifics of iron, B12 folate, and chronic disease-related anemias, detailing the tailored investigation steps, including that absolutely critical check for GI malignancy in certain patients, and finally, highlighting those really significant modern treatment approaches like intermittent iron dosing and standard oral B12.
It really does underscore how a seemingly common symptom like fatigue requires a careful, systematic, and layered investigation to uncover the true and sometimes quite surprising underlying cause. It's rarely as simple as it first appears.
And by walking through these guidelines, you, our listener, have gained insights that are typically the domain of medical professionals, giving you a much deeper understanding of what's happening behind the scenes in an anemia workup and why certain steps are taken. It certainly makes you pause and think, doesn't it? What other common everyday symptoms might also have such a complex and sometimes surprising diagnostic journey hidden just beneath the surface? Something to perhaps ponder until our next deep dive.